So here we are again. Except I'm now changing my hat, changing my coat, and no longer speaking about tumor biology, tumor treatments, and tumors. Instead, even though you might think tumors are my greatest passion, my greatest passion is people. And I'm going to talk about what happens when a tumor is in a person. Now we have a cancer patient, a living, breathing, unique human being who happens to have a cancer. And how do we come up with the best treatments for that person, not just for the tumor, but for the person? How do we deal with physical symptoms? How do we deal with emotional symptoms? And how do we deal with the whole picture? So the second part of the talk is going to be, and all the talks you're going to hear are going to have that as sort of a central focus. There was a great sage in India, Ramakrishna Paramahamsa, who used this ancient Indian parable to discourage dogmatism and encourage working together and speaking together and collaborating. A number of blind men came to an elephant. Somebody told them it was an elephant. The blind man asked, "What is the elephant like?" And they began to touch his body. One of them said, "It is like a pillar." This blind man has only touched his leg. Another man said, "The elephant is like a husking basket." This person had only touched his ears. Similarly, he who touched his trunk or its belly talked of it differently. And so these men of Hindustan disputed loud and long, each in his own opinion, exceeding stiff and strong. Although each was partly in the right, and all were in the wrong, because the nature of an elephant and elephantness could never be figured out until these 10 wise men sat down at a table, talked, shared their observations, shared their ideas, and eventually the idea of an elephant can come out. Keep this picture in mind now, and we'll jump ahead a few thousand years to today. The elephant is now transformed into a zebra, a carcinoid neuroendocrine tumor patient who has a cancer in his or her body. The 10 blind men are now 10 doctors, each one blind to other areas outside their special area of expertise. Okay? And if people are going to come up with a proper solution to solving a treatment strategy and a problem, these 10 blind men are going to have to sit down at a table and talk to each other, or there's going to be a problem. At Cedars-Sinai, we have a neuroendocrine tumor conference that meets every single week, Monday mornings at 7:30 in the morning, and we have people from these specialties sitting and talking and debating and trying to figure out what the best thing to do is, looking at the x-rays, looking at the pathology, and looking at the situation and trying to make a decision. Each one bringing something special to the table: medical oncology, tumor management, chemotherapy, immunotherapy, biologic therapy, targeted radionuclide therapy, all kinds of systemic treatments, endocrinology, management of diabetes, management of hormone secretion problems associated with tumors, radiation oncology, bringing stereotactic radiosurgery for treating tumors in the liver and other parts of the body, cardiology, dealing with carcinoid heart disease and other cardiac issues, gastroenterology, all types of specialized diagnostic procedures, treatment of GI complications, diarrhea, and other things, pathology, making sure that we all know what kind of diagnosis the patient actually has and what's being treated. Is it well differentiated? Is it moderately differentiated? What difference does it make? Interventional radiology, doing radiofrequency ablation of liver metastases, interventional procedures like chemoembolization or radioembolization of liver metastases, and other procedures like that, diagnostic radiology, interpreting MRIs and CT scans, and also suggesting and developing other kinds of special techniques, nuclear medicine for imaging, using all types of somatostatin receptor imaging, CAT scans, MRI scans, and now nuclear medicine is becoming an important part of our peptide receptor radiotherapy treatment strategies. Surgery for removing not only primary tumors, but metastases and cytoreductive surgeries. And we all sit around a table and we all talk. In addition, the patient remaining at all times the center of focus, not the cancer now, the patient. I very specifically use that word. And it's also the whole rest of the team who all put in their very critical part: oncology nurses, nurse practitioners, research coordinators, pain management team, psychosocial team, from psychiatrists on down, dietitians, complementary medicine, even the secretaries who have to pick up the telephone when a distraught patient calls the office and says, "What's happening to me?" Radiology technicians who have to talk somebody through a scary procedure in an MRI machine that might seem claustrophobic. Pharmacists preparing investigational and non-investigational drugs, registration, blood drawing, survivorship programs, scheduling. Everybody involved all has to work together. So I just wanted to kind of put this whole session in the afternoon in a little focus and not take away from the time of my esteemed colleagues who will be following. Thank you. So now I'd like to introduce Dr. Run Yu. Run Yu is co-director of the Carcinoid Neuroendocrine Tumor Program at Cedars-Sinai. I'm co-director as well. I'm a medical oncologist, and I have a major focus, as you know, in treating carcinoid tumors and neuroendocrine tumors of the types we've been talking about today. And Dr. Yu is a terrific endocrinologist, MD, PhD, brilliant researcher in the laboratory, as well as a brilliant physician clinically, and is co-director of the program, is an expert in pheochromocytomas and other types of special neuroendocrine tumors, and also is an expert in all of the hormonal problems associated with neuroendocrine cancer, and we're honored to have him here to speak. Thank you.
Good afternoon, everybody. Yeah, sorry I did not prepare any slides. I just by just discussing with you, and actually I do see quite a few familiar faces from the audience. You may have, some of you may recognize me as their endocrinologist. Dr. Wallen has discussed, the multidisciplinary approach that we at Cedars and many other academic centers have adopted. I cannot overemphasize the importance of a team approach because, as Dr. Wallen has mentioned, that the carcinoid and other neuroendocrine tumors are often called the zebras. And not a lot of people have seen live zebras themselves. So, each of us, based on our own specialty, will contribute to the management plan. And Dr. Wallen has mentioned, the importance of medical oncology, and I agree that I think that really is the foundation of our multidisciplinary treatment approach. And you may ask us, what does an endocrinologist do in helping patients? So we have two main roles in the management of a patient with neuroendocrine tumors. First of all, in the diagnostic process, as Dr. Wallen mentioned that many of the neuroendocrine tumors produce hormones, and each hormone has its own effect. So the effects sometimes are subtle, so that you need an expert to actually recognize the specific effects. For example, you may have, some of you may have metastatic insulinoma, and the diagnosis of the insulinoma is often delayed, sometimes to 7 years, and patients oftentimes were referred as being crazy, but later turned out that the patient actually just has a tumor. Another example is pheochromocytoma, which is an adrenal neuroendocrine tumor, and that can produce very rare and funny symptoms, ranging from some kind of crisis to cardiac complications, and those requires an expert to recognize and to test for those. And our second role is actually mostly in the help management of the complications of the treatment. Most of the treatment, as you already know, are rendered by medical oncologists, with expert as Dr. Wallen. So we help in the optimization of the treatment and in treating the complications. I want to mention diabetes in particular. I gave a talk about 2 years ago in Pasadena about treating diabetes as a complication of neuroendocrine tumor, especially for pancreatic neuroendocrine tumors. And actually, the response I got from that audience was that really nobody has talked about it. It seemed to be very new to even patients. And if you talk with doctors, many of them are not aware that diabetes is a problem in patients with neuroendocrine tumor, especially patients with pancreatic neuroendocrine tumors. Because we have experience in managing and identifying the diabetes problem in patients with neuroendocrine tumors. So we have a special treatment plan for this kind of patient. And we also talk very closely with the medical oncologists and other specialties. And because we have our weekly meeting, we have our monthly meeting, and we talk in the hallways all the time. Of course, we avoid divulging any patient confidentiality while talking in the hallways. But we communicate very frequently. For example, oftentimes Dr. Wallen will call me and say, Ren, we have a patient with a sugar of 180. Do you want to see the patient? And I say, okay, great. I'll see the patient. And then we'll go over the risk factors of diabetes in this patient. And then we are going to design a customer-made plan for treating the diabetes. Our other function would be to follow patients with other complications, such as for example, the patient might already have say metastatic pheochromocytoma. They might have very bad hypertension. They may already have a bone metastasis. Sometimes they can have a constipation, and these complications are often omitted by the treating doctor because when I have a 800-pound gorilla in the room, this is a big metastatic tumor, and then oftentimes you forget that the tumor itself might not cause direct harm to the patient in the short run, but the complications would cause a great deal of discomfort. For example, I have a patient with metastatic pheochromocytoma. She has really bad constipation, but nobody seemed to talk with her about it. And then when I saw the patient, I just say, when was the last time I had a bowel movement? The patient, I cannot remember. So you can imagine the quality of life would be really horrible if you do not pay attention to the complications. So that would be my short introduction of my role, and I think in our next session with individual questions, and we can discuss more about it. Thank you very much.
Thank you, Ren. Next, we'll hear from the gastroenterologist, Dr. Shahab Madizadeh, a terrific gastroenterologist with lots of experience in managing problems associated with neuroendocrine tumors and an important part of our multidisciplinary team. And I think we're honored to have him here today to speak with us. He'll give a little introduction to the types of things that he does. And of course, we'll have an opportunity for a big panel discussion and lots of questions from the audience and a chance to see how different disciplines all work together to solve problems. Thank you.
Thank you, Dr. Boland. Good afternoon. I'm Dr. Shahab Madizadeh, and thank you all for coming. So I want to talk a little bit about the role of gastroenterologists in management of patients with carcinoid. As everyone is talking about, it is a complex disease, and it does require multiple specialties to come together. As you see, even in gastroenterology, we have multiple subspecialties and different physicians who do different areas of gastroenterology that we have to put together. So the role of gastroenterologists oftentimes starts at the time of diagnosis. Sometimes diagnosis is delayed because the symptoms are quite vague. They can be just subtle abdominal pain or diarrhea, and they can go on for quite some time. Other times, patients can present very suddenly with obstruction or bleeding and end up in emergency room. But the role of gastroenterologists is quite vital, and we end up meeting patients quite early in the course. Some of the tools that we offer as gastroenterologists obviously is endoscopy, and that plays an early role in diagnosis. We do endoscopies, colonoscopies, and those are some of the procedures that are done early on. More specialized procedures, such as double balloon enteroscopy, are done by some of our specialists at Cedars. Capsule endoscopy is a small camera that patients can swallow, and it can look in the small bowel. Obviously, we also have endoscopic ultrasound for the pancreas. That's an ultrasound that goes inside and looks at the pancreas very closely from inside the stomach. And these are done by various specialties within the gastroenterology field. Management of a carcinoid, obviously there are many areas that can be affected in gastroenterologists. excuse me, we deal with multiple organs in gastroenterology. So we deal with the small bowel, we deal with the liver, pancreas, and probably one of the most important things that sometimes gets forgotten is nutrition. Within the bowel and the luminal part of gastroenterology, one of the main symptoms is diarrhea and management of diarrhea. The differential diagnosis is quite wide. I have a list of 7 items: carcinoid itself, pancreas-related issues, issues that are related to surgery, such as bile salt diarrhea, that can be related to resection of the bowel or getting the gallbladder out. There can be problems with bacterial overgrowth, problems with short bowel syndrome from surgery, again, microscopic colitis, niacin deficiency. So there's a wide number of different disorders that you have to think about just with one symptom of diarrhea. Obstruction is another problem that we see. A small bowel obstruction can be from a tumor. In carcinoid, small tumors can cause fibrosis and kinking of the bowel. Patients also have surgeries, so they can get adhesions, and that's another area that we sometimes deal with. Liver is quite an important site. It is one of the most common areas of metastases. So we deal with jaundice. That's when the patients can turn yellow from the bile duct obstruction or just from the tumors within the liver. And some of the procedures that are done, for example, ERCP, stent placement, those are done by some of the specialized endoscopies at Cedars. We also deal with liver failure when metastases are more advanced. There are a lot of side effects. There are a lot of problems and disorders that come around with liver failure, such as encephalopathy. Their thinking gets altered from that, or fluid in the abdomen. Those are some of the things that as gastroenterologists we deal with. Pancreatic issues are also quite important. Pancreas is one of the areas that also can tie into nutrition, and some of our treatments can shut off the pancreas, or if there's surgery and people can get exocrine pancreatic insufficiency, they can lose weight. The duct can be obstructed from the tumor, and those are, again, areas that gastroenterologists deal with. Finally, nutrition, that's one of the areas of my interest, and I think that's quite important. People can become malnourished or lose a lot of weight, or most importantly, lose muscle mass from surgery, from chemo, from bowel obstruction, from pancreas problems, and the goal is really preservation of weight and preservation of muscle. There are 2 areas of nutrition, 2 ways that we deal with it. One is oral. Obviously, people can eat. We try as much as possible to use their own gut and advise and guide them in nutrition. And finally, if they can't eat, then there's total parenteral nutrition. That's something that I also manage as a gastroenterologist, and that's giving nutrition by vein when people just cannot eat. And that plays a role in getting people's weight up, giving them muscle mass, getting a better nutrition so they can go to surgery or just be able to tolerate chemo, and that's also important. So I hope that helps. Mainly the point is there's just, even within gastroenterologists, the field of gastroenterologists, there are other subspecialties that here at Cedars and help me and work, we work together also to take care of patients. Thank you.
Thank you. Next, we'll be hearing from Dr. Tom Strauss. Thomas Strauss is the director of the neuropsychiatric program at UCLA, the neuropsychiatric hospital, professor of psychiatry, and he's one of the nation's really bright lights in psychiatric problems, depression, anxiety, pain, and other things associated with complications of having cancer. He was previously here at the Cancer Center at Cedars, where I had the pleasure of working with him when he was directing the program here before UCLA stole him away. And we're incredibly honored and privileged to have him back to speak with us. Thank you.
Thanks very much. Ed, the honor is mine. Thanks for inviting me back home.
Somebody closed our computer out.
Oh, okay. Well, while the computer boots up, I'll just kind of give you the sneak preview. I'm going to talk, actually, Dr. Woolen asked me to talk about 2 important sort of clusters of symptoms in carcinoid depression, not the I'm feeling kind of low today kind, but the kind of depression that becomes an illness in and of itself. I'm going to talk about its prevalence and its nature in carcinoid and its treatment, and then I'm going to talk about pain. And the take-home message is we have safe, effective treatments for both, so if you don't like seeing slides, you don't have to listen. That's the punchline. This is the outline, more or less, of what I just told you. See if I can get the slides to advance. So you guys know the story of what is the biology of carcinoid and neuroendocrine tumors. I'm not going to go through this entirely, just to point out that frequently we know that neuroendocrine tumors produce serotonin, and if you're a psychiatrist, that immediately grabs your attention because we think and talk a lot about serotonin in contemporary neuroscience and psychiatry and pain. So we'll come back to the serotonin topic in a moment. Here is the evidence from actually probably the best study done on the topic, Lancet Oncology just last year, looking at about 400 studies done over the last 4 years. So the thing that some people have called the noonday demon, the disorder of major depression, the thing that goes on for weeks and weeks at a time where people have sleep difficulties and low mood and hopelessness and helplessness and a change in personality and irritability and apathy and lack of interest in ordinary activities and inability to respond to good medical news like we can't find any detectable evidence of your carcinoid tumor on your recent scans. That kind of depression occurs at a rate of about 16% in folks with malignancies. There is no good evidence that that number is any different in carcinoid as in any other tumor. There are certainly people who strongly believe that there's a difference, but no one has been able to demonstrate that. And it would only be fair to say there haven't really been any serious efforts to study that, so it could well be wrong, but that's what we're going on. Anxiety disorders, slightly lower prevalence, as you can see, about 10%. This is the point I just made. When I was here at Cedars working with Dr. Wolin as he was building the neuroendocrine program, a very thoughtful patient with carcinoid tumor said to me, if my tumor makes too much serotonin, and we think a serotonin problem, like a deficiency in serotonin in the central nervous system, has some role in the causing of depression, why am I not happier, right? I have too much serotonin circulating. I should be joyful, right? It was actually a very thoughtful question. Without going too far back into basic anatomy, it's worth pointing out that the excessive serotonin production that a carcinoid tumor may make is in what we call the periphery. It's in the intestine or the liver. And it doesn't cross that very special membrane called the blood-brain barrier. It's the thing that protects our central nervous system, a highly conserved organ from all kinds of stuff that's circulating in your bloodstream. So even if you have the carcinoid syndrome and have massive amounts of serotonin in your bloodstream, it's not going to get into your brain and it's not going to affect your mood in the way that my thoughtful patient asked. There's one other interesting sort of counterpoint, which Ed and I just talked about the other day, which is that we do know that when your tumor is making massive amounts of serotonin, it consumes tryptophan like crazy, and tryptophan is a dietary substrate, and you need tryptophan in your central nervous system to make serotonin. So if you're using up all your tryptophan to make serotonin in your gut, it's a reasonable question as to whether you might have not enough serotonin or not enough tryptophan in your central nervous system to make the serotonin you need to have a normal mood. No one's ever shown that that's the case, although there have been some interesting efforts in the study of depression in healthy people that show if you deplete tryptophan in diet, you can actually induce symptoms of major depression. So it's a curious sidelight, but we again have no evidence that this is how it operates in persons with carcinoid. What about another very salient question, a topic that Dr. Wolin and I have discussed many times over the last decade, which is if we're treating a person with depression who has carcinoid and we're using what we call serotonergic antidepressants, might that exacerbate their symptoms, their carcinoid-like symptoms, because we're giving them serotonin, and although the target is this, we're not giving them serotonin, we're giving them a drug that delays your body's reuptake or metabolism of serotonin. And although the target is the central nervous system, the question is, might giving it orally, it's absorbed into the bloodstream, and that's how it gets to the brain, where it does cross the blood-brain barrier. Might that exacerbate carcinoid symptoms? It might. It doesn't seem to be what happens clinically, however, and I have met tens, and my guess is Dr. Willen has met, and Dr. Yu have met hundreds of people whose carcinoid diagnosis has been missed for so long that they have either been treated for a depression that they don't have or have developed depression, and so they've been on one of these serotonergic antidepressants for a long time and tolerated it okay. So again, a theoretical concern that doesn't seem to bear out. Fancy cartoon, more or less summarizing what I just said. What do we do to treat depression? So we do in carcinoid and other malignancies what we do in medically well people, although we adopt it in ways that work for individuals. We, of course, help with various forms of psychotherapy that might work for an individual, various medication approaches. The best evidence says that probably the most effective treatments combine those two things. There is evidence that exercise is antidepressant. It's a small effect, but it's a real effect in the literature. And there is some evidence in support of some of the CAM approaches. There are some good studies of St. John's wort, some good studies of S-adenosylmethionine. Of course, the refrain that you've probably now heard a million times is, the hard thing about those is you don't really know what you're getting, even if you're buying from a reputable CAM supplier. The production of these things is simply not regulated in the same way that what I like to call the pharmaceutical industrial complex that we all resent but live with that produces prescription FDA-approved medications does. So, and I would urge you, if you're doing any of that stuff, to be sure that your treating physicians know about it, because there also is an issue about interactions. You probably have seen this list since they seem to be on the front page of the LA Times most days. I don't think there's any news here. The serotonergic agents that sort of began the modern era, or the SSRIs, the dual action or SNR agents, and the sort of drugs that have unique pharmacology. Mirtazapine is an interesting one because mirtazapine actually blocks serotonin receptors in the gut and can actually be a treatment for some of the nausea or increased bowel activity that can be characteristic of carcinoid. But of course, my colleagues have lots of very good serotonin blocking drugs up their sleeve too, like Zofran and its brothers and sisters. So that's the depression part. I told you I'd be quick, and we can talk about it in the discussion period if you'd like. A little bit about pain. So I think it's fair to say, and the evidence says, that the most frequent site of pain, not surprisingly, in carcinoid is the gut, associated with carcinoid tumors themselves. Some people, though, can get very significant pain associated with carcinoid syndrome, particularly visceral cramping, viscera, your intestines, the hollow organs that form your bowel. And we've all had visceral cramping as part of normal living, but the visceral cramping of carcinoid syndrome is really, I've not had it, but I have certainly spent time with people who have it, is really a whole other order of magnitude of pain. On the rare circumstance where a person might develop metastatic carcinoid to bone, there are some unique kinds of bone pain that are characteristic. Some people get arthralgias, that is joint pains, not from metastatic disease, but simply from the inflammatory process or immune response to carcinoid that manifests as something like an arthritis-like picture. Some of our carcinoid treatments can be moderately painful, although that's not a frequent issue, and then there certainly can be sundry other kinds of pain problems. If I failed to mention them, I'm sure you will tell me in the discussion what I failed to mention. And there are, again, some evidence-based mind-body interventions that can be very effective for pain, and those include a variety of meditation, imagery, relaxation strategies, certainly some movement approaches. I'm using generic terms. For one man's yoga may be another man's cross-training. Different kinds of movement approaches can be effective for pain, and certainly some breathing strategies also have been shown to be useful. You may have seen this before. This is something that every oncologist and every pain physician could recite from memory. This is a World Health Organization kind of public health guideline for pain management, specifically medication pain management. And it was actually developed for countries that have almost zero access to prescription medicine. So it's a little bit silly in North America to show this, except it's still what we all refer to. But if you're in the African plain and you're having a pain crisis, the World Health Organization Stepladder for pain suggests you start with something simple, like acetaminophen or aspirin or a non-steroidal anti-inflammatory, and kind of work up slowly. And you might work up to the level 3, which is a strong opioid, a drug like morphine or oxycodone or hydromorphone, and maybe another kind of pain medicine that works by a different mechanism. And that's really how we do pain management in oncology. We do it in a stepwise graded way. And I guess I want to say one other slightly editorial comment, which is, despite what you read in the newspaper about reckless prescribing and people using opioids for non-therapeutic purposes, in competent prescribing hands, taken responsibly as directed, these are incredibly safe and effective drugs. And it's a terrible injustice to everyone with a malignancy that our culture is kind of going in the wrong direction to believe what we believed 50 years ago about that. Okay, end of soapbox. Some of the drugs we use include, as you can see, salicylate aspirin, non-steroidal inflammatories, Motrin, and its brothers and sisters, acetaminophen, Tylenol. And of course, the most dangerous drug up here is Tylenol, because people can take enough of it to actually harm their livers. And back in the day when I was a liver transplant psychiatrist, we used to see 3 or 4 patients a year who either intentionally or unintentionally need a liver transplant because they'd been taking more than 8 grams a day of acetaminophen for a long time, mixed in with their opioids or for some other reason. So, and I don't need to say that because we have a gastroenterologist in the room who lives and breathes acetaminophen toxicity and can tell us more about it. The purpose in showing you this is simply to point out that we have an incredible range of safe, effective opioid molecules, and they work well, and again, a capable pain physician knows how to choose among them and to find one that a person can tolerate side effect-wise and route of administration-wise. We have a lot of flexibility in that regard, and route of administration, so I think you probably know this stuff, but we have oral formulations, both fast-acting and slow release. We have skin patches that release medicine through the skin into the bloodstream, so you actually don't have to have a working bowel in order to absorb and benefit from those medicines. We have very rapid release medicines that you can put under your tongue or across the mucous membranes in your mouth, which work almost as quickly as an intravenous infusion, and which really have revolutionized how we manage breakthrough pain in the last 10 years. And some of these medicines can also be given rectally. They can be given, of course, intravenously, and sometimes intraspinally in unique situations where that route of delivery is needed. I think I'm going to finish well before my 20 minutes, but just to point out some other medicines we use for pain, those include corticosteroids, which when something that ought not to be pressing on an important structure is pressing on an important structure and causing swelling and inflammation, corticosteroids can be incredibly pain relieving. Occasionally, bisphosphonate medicines, which are used to either prevent or treat some of the skeletal complications of malignancies, can also be analgesic or pain relieving. We've seen some very dramatic examples of that in the last 15 years. A hormone called calcitonin, which your body makes and uses to regulate calcium metabolism, can be effective for bone pain. And then, of course, the unspoken topic today, but perhaps you'll be interested in, that is what is the role of marijuana and its metabolites in pain management. So I think the role, I'll try to summarize what I think the literature supports. There actually in the last 5 years have been 2 or 3 good studies that have shown that in one form or another, cannabinoids, the fancy term for marijuana and its metabolites, can be effective for certain kinds of pain. In particular, what we call neuropathic pain, pain associated with injury to nerve. And typical examples of that are the pain associated with diabetes, or for people who've had certain kinds of chemotherapies, peripheral neuropathy from chemotherapies, although those chemotherapies tend not to be used very much in carcinoid. There's not really any good evidence, although there are lots of people with very strong personal beliefs about this. There's not really a lot of good scientific evidence that cannabinoids work for other kinds of pain, but we all know people who have had the experience of that and who feel cannabinoids work better for them than various prescription things that they may have tried. So, power to the individual, that's fine. The only other caveat, the usual one, is if people are going to be inhaling and burning marijuana, although we know there are many alternatives with vaporizers and eating various preparations, if you're going to be scorching your lungs, you probably want to let your doctor know about that too, because of the whole impact on your risk for respiratory infection and that sort of thing. I wasn't trying to be a smarty pants. I was just, certain interventional nerve blocks can also be effective for pain. The evidence for acupuncture, although I'm an acupuncturist, so I wish it were better, but the evidence for acupuncture is that it's not very effective for cancer pain, although that's old data, and I actually think it's maybe not quite as bad as a C, maybe a B. So last slide, again, the take-home, which is what I told you at the beginning. You and working collaboratively with your treaters can, I think, very effectively manage carcinoid-related symptoms. The ones I've emphasized are depression symptoms and pain. And I think the important thing, it may be so obvious as to not need to be said, except sometimes people don't do it, so I'm going to say it. And that is, let your team know about your symptoms, because we don't always know. Work collaboratively. If we're not getting it, tell us again or express it a different way. If you can measure the impact of what you're doing in some reliable way, like using a pain rating scale or a mood rating scale, that will help you and that will help us know how we're doing. And please, again, let your treaters know everything you're doing, not just what we think you're doing, but the other stuff too. Thank you very much.
Thank you for that awesome summary of psychiatric aspects of carcinoid. We're now going to be hearing from Dr. Arash Asher, who's the Director of Cancer Rehabilitation and Survivorship in the Samuel Ocean Comprehensive Cancer Institute, and is a wonderful physician specializing in symptom management and helping people cope with various complications of having malignancy in their body. Thank you.
Good afternoon, everyone. I know we're approaching the end of the conference and it's Friday afternoon, so I thought it would be appropriate for me to talk about fatigue, particularly cancer fatigue.
This one.
This one here. Neuroendocrine. Neuroendocrine 2013. Yeah. So, again, I think this is a very common problem for people going through different stages of treatment, and there are things that we can do about fatigue, which is why I think it's worth talking about. I think the first slide is particularly important for all the caregivers and spouses and friends in the room, because people who have not experienced cancer-related fatigue probably don't understand how profoundly it can affect you. If you are extremely tired from my talk and get bored, you'll take a nap later today, you'll go for a walk, you'll forget about this, and your energy will return back to normal pretty quickly. That is normal fatigue. If somebody stays up all night, you get some rest and you feel better. People who are experiencing cancer-related fatigue have a much more persistent amount of fatigue regardless of what you're doing. So they could just do some dishes, some light housework, a few errands, and they can complain about this all-consuming fatigue, which is why it's much more disabling. So this is a busy slide, and I don't mean to go through all of these details, but I wanted to really emphasize all the myriad of causes that contribute to cancer-related fatigue. And if we start on the top left in the red, obviously chemotherapy agents, some of the targeted agents, perhaps the underlying tumor itself can contribute to fatigue. It seems that some people may have a genetic vulnerability that may contribute. There are hormonal changes that may be occurring in some situations. But there are many other factors, and those are the ones in blue, that contribute to fatigue that we still have some control over. There are other medical issues that sometimes can be pretty easily optimized. So if your thyroid is low or if you're anemic. Dr. Strauss talked about pain. If you're in a lot of pain, you could be fatigued, or if you're being over-medicated with pain medications, that can contribute. Some of the side effects for example, medicines for nausea or medicines used for sleep sometimes can contribute. Sleep. Approximately 50%, it's been reported, of people going through treatment don't sleep well. And if you've gone through just 1, 2, or 3 nights of poor sleep, let alone weeks and months of poor sleep, you could see how easily that could contribute to the fatigue problem. Depression and anxiety that Dr. Strauss was talking about, that could obviously contribute. Last time I was here last year, we talked about chronic stress and isolation, and that can play a role. Poor nutrition, the loss of muscle mass, and the inactivity and deconditioning, all of these things can contribute. But I think, even though we don't have time to go through these details today, there are a lot of areas where you can still make an impact and still rectify some of these factors that contribute to the fatigue problem. I did put one area in yellow, cytokines, and that basically refers to inflammatory chemicals that are produced in our body that we think may be the primary culprit in this fatigue problem. And it seems that many of these other problems that we're talking about, whether it's depression or chronic pain or chronic stress or poor nutrition or lack of exercise, all of these things contribute to the production of these cytokines, which then we believe contributes to this fatigue process. And again, I'm throwing a medical slide up here, but this is to highlight this idea that our immune system interacting with tumor cells combined with perhaps psychological stress and maybe some of the chemotherapy agents, all of these contribute to the production of these cytokines, which we believe contributes to this fatigue process, maybe depression, and maybe some of the so-called chemo brain or cognitive dysfunction issues. So the reason I bring up this issue of cytokines, which again, these are these inflammatory chemicals that we experience, for example, when we have the flu. So if anyone's had the flu, you know that for those 3 or 4 days, you feel extremely tired. And the reason you feel very tired is not because of the flu itself, but because of your body's immune response to that flu. And that response has to do with these inflammatory chemicals. Now, when you're experiencing cancer fatigue, we believe that these inflammatory chemicals are being produced on a longer-term basis. So we're not talking about a 1-week flu anymore. And the reason why we believe exercise may be so important for helping cancer-related fatigue is because we know that exercise reduces inflammation. It is probably the best anti-inflammatory medicine that we know of. And this is kind of a simplistic diagram, but this is what often we see happening here with many of our patients going through treatment, where for all the reasons that we talked about, fatigue exists. And when someone's tired, of course, our first reaction is to sit around and not do anything. So you're fatigued, you're inactive, and then prolonged periods of inactivity leads to deconditioning. And then, of course, when you get deconditioned, you get more fatigue, and then you do less, and you could see very easily you can get caught up in this vicious cycle. What we try to do is when you're going through cancer-related fatigue is to try to introduce, and I want to emphasize, a personalized therapeutic exercise program. So when you experience the fatigue, even though it's counterintuitive, to help people find an exercise program that's appropriate for them, that improves your endurance, and that hopefully improves your energy. Then you're able to hopefully exercise more with time and to try to get people into this type of more positive cycle. I'm going to talk about fat for a second because I think it's also related to this inflammatory process. And we know that there are 2 types of fat, and you've probably heard of this idea of being apple-shaped or pear-shaped. And the reason why being apple-shaped is associated with many of our chronic health problems, such as diabetes or heart disease or dementia, is because the fat that develops deep in our gut by our liver and our pancreas and those organs, that fat produces more of these inflammatory chemicals. The fat that we believe is underneath our skin and our arms and our legs doesn't seem to be as harmful. So it's the deep fat that we're worried about. The problem is that when you're inactive, we rapidly can accumulate this bad fat, this visceral fat. And this is just a little study that I thought, tells this story pretty well. This is a study of, granted, these were not patients with neuroendocrine tumors. These were college kids, didn't have any kind of cancer. And what they did was they had this group of college kids go through an MRI, and they actually measured their bad fat, that visceral fat, and that's what the arrows are pointing to on the left. And what they had them do was they just had them go through 2 weeks of inactivity. So they had them going from about 10,000 steps a day, which is a reasonably active lifestyle, to just 1,500 steps or less per day. And in just 2 weeks, they put them through the MRI machine again. And as you can see, in just 2 weeks, the arrows pointing to the area in white refers to the visceral fat. Their visceral fat increased by 7% in just 2 weeks in healthy college kids. So we can imagine if someone's going through weeks or months of treatment and is caught in that inactive cycle, what may be happening to their visceral fat and how that may be contributing to their fatigue and maybe some of their other long-term problems. So the good news is, even if we don't lose weight when you exercise, you decrease your visceral fat. And this is why we talk about the idea that it may be more important to keep track of your waist circumference rather than looking at the scale, because exercise isn't probably a great tool for weight loss, but it can still help get rid of that bad fat. And we know that regular exercise can reduce those inflammatory cytokines, these cytokines that we think are associated with fatigue and depression and maybe some other chronic health problems. There's one other point I want to make with regard to exercise, and I think this is particularly important for people going through cancer treatment. The dosing of exercise seems to be really important. Now, we know that if you're a couch potato and if you're sedentary, that your immune system doesn't seem to be working optimally. But what we're also learning is that if you're involved in very intensive exercise, that you may be also potentially suppressing your immune system. So you know that if we look at marathon runners, for example, they get more colds, they get more infections, they get more flus. If you give a vaccine to someone who's training for the marathon, they get a dampened immune response compared to people who are getting moderate exercise. So if that's the case, it's really important to make sure you're staying in a moderate zone of exercise, particularly when you're going through some of the intensive cancer treatments. Now, I think the challenge with that is figuring out what's moderate for you and what's moderate for me and what's moderate for an elite athlete is going to be three different things. And what may be moderate for you in the midst of all your treatment compared to what was moderate for you a year ago or 2 years ago before you started treatment may be two different things. And this is when it's really useful to help to work with a therapist or a rehab individual to help figure this out. I'm going to skip this slide, but it's basically saying the same thing, that if you're inactive, it's associated with chronic inflammation and these inflammatory cytokines and chronic illness. If you're active, it seems that it has an anti-inflammatory effect. And the ultra-marathon runner or somebody who's performing extreme performance exercises may be causing temporary immune suppression, which I think is the last thing somebody wants to do when you're going through cancer treatment. At Cedars, we've actually started a personalized cancer exercise recovery program, and I'll be happy to answer questions about that later. And I think for the sake of time, we'll stop right here, and we'll be happy to answer questions at the end. Thank you very much.